We're a 200-bed not-for-profit community hospital here in Silicon Valley, California. We opened in 1950. We have a CMS 5-star rating. We are in the top 2% nationwide for health grades, combined outstanding patient experience and safety awards. And some of our top performing service lines are cardiac, vascular, and orthopedic. So we don't typically run 200 inpatient beds. Usually our average daily census, because this typically comes up, is closer to 70. So just as a little bit of background on us. And then I'll go back to the time before Ceribell in 2018 and kind of just go over what did it look like for us for EEGs. Well, we had very limited access. We had one part-time EEG tech. We had a lot of difficulty hiring and finding EEG techs. We had 2 neurologists who would read. And we shared an EEG machine between inpatient and outpatient. And typically, if we had a stat inpatient come up, if the machine was being used by outpatient, that inpatient would have to wait, which was unfortunate. Or if we were doing an inpatient and then got an outpatient, then that person would wait. So it wasn't a great flow for our patients. Typically, the part-time tech was here between the hours of 8 and 5. Occasionally, we would be able to ask that tech to come in for an after hours if they were available, but it was hit or miss. And so typically was not unusual to wait 10 hours or even 2 days if something came in late on a Friday night. And then, of course, it's always difficult to do 24-hour continuous EEGs. The tech can't be there the whole time. Sometimes leads would come off and things like that. And so how did we treat seizures? It was basically by clinical judgment. We had very limited diagnostic support, like I mentioned, and it was really caregiver dependent. If they felt strongly that it was a seizure, they would just treat it empirically. People have asked me, well, did you transfer? You're in the heart of Silicon Valley. For folks that know the area, Stanford is right around the corner. Would you transfer to Stanford? But the fact of the matter is it was very difficult to even get a stat EEG at Stanford at the time. So that was problematic for us. And we knew that it was a concern in terms of our patient care. So, but one of the things that we didn't realize that there was any option. And so when I was approached by Ceribell, originally they were talking a little bit about, would this work for your ICU? That made sense. But really, my background's in the ER nursing, and I thought, gosh, I think this could really be helpful in the ER. I know when I was at the bedside, often we would want to have an EEG, but the fact of the matter is I just didn't know because the ER almost never ordered an EEG. So I went to the ED director and I said, hey, if you had a rapid EEG available, what do you think? Would you use it? And he literally said I would probably order one almost every day that I worked. So, but why? Why do we want to do a rapid EEG? And what you can see here on the left in the orange chart is really just a graphic showing that the longer a seizure goes on untreated, the less likely it is to respond to the first anti-seizure medication. And that's particularly important because on the graph on the right here, what you see is the longer a seizure goes on, the higher the morbidity and mortality of the patient. More recently, for 2022, the Joint Commission has changed their requirements, which is very interesting. And my team is working on making sure that we follow all of the new guidelines. The requirement is that for all cardiac arrest, post-cardiac arrest care, that you align with the 2020 American Heart Association ACLS guidelines. And what do they say? They say comprehensive post-cardiac arrest care is necessary to address the systemic effects of the ischemia reperfusion injury following cardiac arrest. So, yes, even I stumbled over that big long. What does that mean? They recognize that it's critical for patient survival and for optimal neurological outcomes if we follow these guidelines, these evidence-based guidelines on the right. So for either a nonverbal or awake alert patient, they recommend EEG monitoring. So what is Ceribell and what does it do? Well, it's a rapid EEG. It's a very simple headband that can be placed in 5 minutes or less by just about anybody. It's point of care. So you just literally go to the bedside with this headband, you put it on the patient. Again, it can be applied by anyone. Here at Sequoia, we use respiratory therapists, and I'll talk about that a little bit more later. And then it allows a very complicated AI algorithm that I will not explain, basically comes up with a seizure burden. And so right there, within a few minutes after applying it, you will see whether or not the patient is having seizures. And that's so important, because in the past, we would have to wait for the neurologist to read the paper EEG, and that could have also led to delays in patient care. But now with Ceribell, they use a cloud. It's uploaded real time into the cloud. As soon as we call our neurologist, they can begin viewing that EEG that's being sent to the cloud using Ceribell. So what's our policy and procedure? Obviously, for any kind of indication that you see here on the left, we order a rapid EEG. And so that would be post-cardiac arrest, as we mentioned before, unexplained or persistent altered mental status. That could be with a traumatic brain injury, a stroke, possible CNS infection, any kind of episodic repetitive movements. If the patient has had a recent seizure or is in status epilepticus, with or without a return to baseline, we typically will order. Again, as I mentioned, it's ordered rapid. We use our respiratory therapist to apply it and set it up. And I did that because I thought it was important to keep the smaller group of staff competent. And I felt that to train 400 nurses and keep them competent in all of the units, not just the ICU, but in the emergency department, on our telemetry floor and on our med surg floor, I felt it would be more difficult. So our respiratory therapy team is about 25, and that was a little bit easier. So they set it up, and they do the initial spot check for seizure burden. If they see a seizure, they obviously tell the ordering physician and call neurology, and then the seizure would be treated. If they don't see it, then what happens is obviously the Ceribell stays on. The nurse then monitors the connection after movement. If they have to turn and position the patient, or if for some reason the patient needs to get up, they can check that. And then obviously, as I mentioned, once we get the output either from immediately that there's seizure or the neurologist reads it, then we can go ahead with treatment. But, people have also asked me what really matters to me as the chief nurse and the chief operating officer. And I always say that the very most important thing for me is always patient care. And as I mentioned, we knew we were missing seizures because we really couldn't get access to it. And we wanted 24/7 access, but with smaller hospital, it doesn't make sense to have an EEG tech, sitting around waiting for maybe, that one EEG that might occur during their shift. We knew we needed ED coverage, but again, it was really hard to justify. Not only was it hard to justify an EEG tech, but it was hard to train one. As a matter of fact, I had a respiratory therapist at the time who was very interested in learning EEG. And we spent several $1,000s to send this tech all the way to North Carolina to get a 2-week training for EEG. And just to find out about 8 months later, she left us for another organization. So that didn't work out so well. So we knew we had some troubles there. The other area that was so important to us is length of stay. And we knew if we had patients waiting around for EEGs, it was likely impacting our length of stay. At Common Spirit Health, for those of you listening who are with Common Spirit, it's so important length of stay that there is a new directive that the C-suite needs to attend our discharge rounds, or here what we call them as our multidisciplinary rounds. And those rounds occur every day, Monday through Friday, with our care coordination team, with our physicians, with our bedside nurses, charge nurses, social work, and many other folks from the multidisciplinary team. And the whole point of that is, where is the patient in their stay, and what are the objects or issues that might be stopping their discharge? What needs to happen? Do they need physical therapy? All of this multidisciplinary team comes together and talks about how do we get this patient safely to discharge. It's so important that they've mandated that, again, the C-suite be there. For my role, I need to be there at least twice a week. The hospital president is expected to be there at least once a week. The chief medical officer is expected to be there twice a week. And more importantly, I think the impact of length of stay on our bottom line is so important that our CFO is expected to be there twice a week. So shortly, about 6 months or so after we got Ceribell in place, I really wanted to look back and see what did we get out of implementing Ceribell. Did we really improve our time to EEG? What departments were using it? Did we increase seizure diagnosis? And what happened with our length of stay? So we took a look at the 6 months prior to putting Ceribell in place and looked at our conventional EEG data versus the 6 months of Ceribell data. And that's what I'll kind of go through next. So did it improve access? Well, in the 6 months prior, we had only 35 conventional EEGs completed, whereas the 6 months post, it was 115. You can see, too, the areas. I mean, look at the ICU, 40 versus 16. CSU is our telemetry unit, so 41. Again, remember, we have heavy cardiac and vascular, so that kind of makes sense. And then our ED, now, while they didn't order one every single day in 6 months, they clearly were ordering more. And now, more recently, we've looked back at our data, and in fact, our ED is ordering a significant amount more nowadays. All right, and did we find more seizures? Actually, we did. 0 in conventional, which is not surprising since most of the time they had to wait a long time and were probably, if there was a high suspicion, already treated for seizure. But with rapid EEG with Ceribell, 23% of those detected seizures. So we were getting more seizures, which is great. We were finding them and treating them. So it really was impacting clinical practice. You know, and people ask me sometimes rapid Ruleout versus rapid Rule-in. Well, rapid Ruleout is just as important, right? Because we limit unnecessary treatment like medications for seizures that if they don't have it. Emergency department physicians have told me they can get the patient either admitted more quickly because they know they've ruled out seizure and they're kind of finding a new differential diagnosis, or even for some cases, the patient's able to go home. And then, of course, if we're not loading somebody on a heavy anti-seizure medication, we're going to reduce ICU admissions. For rapid seizure diagnosis, makes sense. We talked about the increased morbidity and mortality when we wait to give anti-seizure medications, and so we're going to resolve the seizure sooner. We're also going to capture diagnosis if clinical suspicion is low. So in the past, if the clinical suspicion was low, that really became the very last thing, and often the physicians just didn't even bother to order it because they knew they couldn't get it. And ultimately, it really is the best practice. It's the best practice because we know we can rule in or rule out seizures right away, which is important for patient care, so much so that, again, in this subclass of cardiac arrest patients, the Joint Commission has said it's a best practice and we want it to be followed. So was it rapid? So we went from an average pre-Ceribell of 9.6 for conventional EEG down to 1.2, so a little over 8 hours faster. And that's 39 days essentially saved waiting around for EEGs. So what did it do for our length of stay? This was the one that actually surprised me when we went through this. I knew faster EEG was going to get a faster diagnosis and faster recoveries and have folks out. I did not realize that there would be a 3-day reduction in length of stay. So conventional EEG, patients that had a conventional EEG order stayed an average of 7 days versus the rapid EEG 4 days. So that's, really impressive and something that I was actually quite surprised at. So I mentioned earlier that the rule in and rule out and this idea of even a low likely suspicion and how it impacts patient care. So we had a 93-year-old female that came into our emergency department with altered mental status from a nursing home, had a history of a recent UTI. The altered mental status, obviously, we went down the rule-out stroke pathway, went right to the CT scanner. Patient did not have a stroke. Again, started to think, well, okay, this could be the UTI back, but went ahead and put a Ceribell on because, again, the altered mental status that was unexplained. In fact, the patient was having a seizure. In the past, the physician said I would have never even bothered to order an EEG because my suspicion was really low and I really was going to go down this sepsis route, right, once I had ruled out stroke. And so it clearly changed the course for that patient. And then we had a patient that was called by our EMS. The patient was having some weakness and a little bit of altered mental status, and it was called in as a post-stroke. Made sense. Again, went down the stroke path, ruled out stroke, was in the CAT scanner, was getting ready to go to the MRI. And in the meanwhile, while they were completing the checklist, they put a Ceribell on, and in fact, this patient was having seizures. So really important, again, lower clinical suspicion. In the past, the physicians said I probably would have never gone down the seizure pathway, but we had access to this point of care EEG, and I was able to change the course for that patient. And of course, it comes up always the finances of 24/7 EEG, right? And so there's kind of the easy to measure things, right? I mentioned before that the respiratory therapists were putting it on. I did not have to add any respiratory therapists. And so you can really take a look at, whether or not you need to add FTEs. In fact, I didn't. The equipment is again, very simple. The billing, and we'll talk a little bit more about that. And obviously overtime, and you can look at in the past when you would have to call an EEG tech in overtime to complete a stat EEG. But there's other things that I think are important to measure. Now, this wasn't the case for Sequoia, but for some places, they're actually transferring patients out if they think they need an EEG. So unnecessary transfers, for sure, you can take a look at that. You capture missed MCCs and CCs for your DRGs, and we'll talk a little bit on some dollars and cents on that in a moment. Reducing admissions from the ER overall for those handful of patients that you can actually rule out and send home. Lowering our ICU length of stay, intubations and medications. And then, frankly, for us, and I think others would find this, really raising our staff satisfaction. The EEG techs really were very satisfied that they could focus on the outpatient EEGs. And our respiratory therapists were really excited to do something else that was within their scope, but very different from what they typically would do. So looking at whether or not Ceribell actually does save money, we took the length of stay of 3 days. We multiplied the average weighted cost. And when I say weighted cost, we recognize that of the 63 admitted patients, not all of them would typically go to an ICU. As a matter of fact, it's only a small percentage of them would go. And so we sort of weighted the cost of an ICU day and the cost of a typical telemetry bed. And we look at that out of the 63 patients, and we know that a savings over 6 months is a little under $270,000. So it really did save us quite a bit of money. And again, as I mentioned, you can't bill for what you can't diagnose. So we looked at our patients that did have seizures, and we were then able to capture the CC or MCC for that. You multiply that out and project that onto an annual revenue for appropriate billing for those upcodings, and it would be about $146,000. So also quite impactful. I mentioned earlier about the staff satisfaction. I think, for one, the respiratory therapists were, again, excited to do something a little different. But really, for anyone, they can be trained in an hour. They can apply it in 5 minutes, and it's not a really complex thing that adds like one more thing onto someone's plate. And we really want to, for our staff and for our physicians, we really want to provide the best care. We want to be confident that what we're treating is appropriate. And so this really makes the team feel much better. For us, our neurologists still locally read. That was their choice. But for some rural hospitals or hospitals that really just can't get their hands on 24/7 neurology, it really can be a game changer to have the teleneurology option. So, I talk about Ceribell sort of being plug and play, but there are some key things that you really want to get buy-in. So for us, we really knew that we had most of our intensivists, that those are the ICU physicians, and our neurologists knew we were taking too long to get EEGs. And so they were excited to hear about a rapid EEG process. But getting the emergency department physicians, the hospitalists, and others bought in, as well as whoever you just determine is going to be putting it on, is getting them engaged up front. And then you want to protocolize it. So you would want to say who's going to order it, who's going to put it on, who's going to read it. And then, do you want them to read immediately, remotely, or, based on urgency, and you'll kind of protocolize that as well. For some hospitals, there could even be a conversation about, could this be a nurse-driven protocol based on certain symptoms? That's also an option that you can work out with your medical executive team. But certainly, we know that seizures can happen anywhere in the hospital. We know we want to catch them early because it's the right thing to do for our patients. And so we really want to, take a look at what existing staff could take care of it. We know it can be done by almost anybody. We really know that it'll have an impact on length of stay, and we know it can also limit both admissions and transfers, as well as just have a profound economic impact and a profound care impact for our patients.